Hello everyone, I am back again with a pediatric case at an unusual location. A 15-year-old boy presented with headache, giddiness, generalized weakness and imbalance while walking. He underwent MRI. You can see there is a large solid cystic tumor present at the left CP angle. So the MRI findings were a large extraaxial SOL in the posterior fossa, left CP angle cistern, peduncular cistern inferiorly extruding into the CS space up to foramen magnum and superiorly up to the roof of the third ventricle. The mass is predominantly cystic with fluid signals within, and it showed multiple calcified foci in the left CP angle as well as in the third ventricle. This was causing considerable mass effect on the fourth ventricle, resulting into obstructive hydrocephalus. So, a diagnosis suggestive of congenital teratodermoid tumor was done on imaging. We received a single irregular grey-white soft to firm tissue piece measuring 1 into 0.5 into 0.2 centimeters in our lab. The histopathology revealed presence of a tumor composed of anastomosing epithelial islands lined by stratified squamous epithelium which showed peripheral nuclear palisades. Wet keratin and ghost cells were also present. Now the epithelial islands were separated by loose stellate reticulum. Cystic degeneration was noted along with areas of hemorrhages, foci of calcification, and numerous cholesterol clefts were seen. You can see the second slide which shows extensive foci of calcification and cholesterol clefts. We did immunohistochemistry which revealed EMA was positive, CK7 was positive, P63 was positive, and the beta-catenin showed nuclear positivity in the proliferating cells. So a diagnosis of adamantinomatous craniopharyngioma WHO grade 1 of the left CP angle was given. Now the CP angle tumors could arise from neuroglial tissue, cranial nerves, meninges, blood vessels, bone, cartilage or embryonic remnants. CP angle lesions are commonly found in adults than in childhood. The most common CP angle tumors in adults are schwannomas, meningiomas, epidermoid tumors. These tumors are rare in childhood, but we must always expect them in case of neurofibromatosis type 2. Now, this is a table depicting the two types of craniopharyngiomas, that is adamantinomatous craniopharyngioma and papillary craniopharyngiomas. The APC, that is adamantinomatous craniopharyngioma, is most common in children and adults, while the papillary one is common, predominantly found in adults. The location for APC is suprasellar, sphenoid sinus and CP angle, whereas for the papillary, it is most frequently found in the suprasellar and the third ventricle. Visual disturbances is present in both the cases, and depending on the location, they will come up with the hormonal disturbances. Grossly, the APCs are solid and cystic, and they contain the machinery fluid or the greenish liquid that is also called as motor oil like fluid. And the papillary craniopharyngiomas are most commonly solid in nature, and the cystic fluid is absent, and if at all it undergoes some cystic degeneration, then the fluid is clear. In APC, the epithelial cells are arranged in cords, lobules, whorls with peripheral palisading of the columnar cells, and these are separated by loosely arranged epithelium called as stellate reticulum. Now wet keratin is a hallmark of this variant, and the wet keratin is absent in the papillary variant. And papillary variant, it has a well differentiated monomorphic columnar or squamous epithelium along with a fibrovascular core and a thin capillary network with scattered inflammatory cells. The molecular findings are as follows. For APC, a mutation in exon 3 of the gene encoding beta-catenin with activation of WNT pathway is most of the times found, whereas the characteristic for papillary craniopharyngioma is BRAF point mutations suggesting activation of MAP kinase pathway. Thank you very much. I hope you all enjoyed this case.